Let us begin the first on this series of COVIMPRESSIONS, the webinar to talk about our impressions of the COVID pandemic. So Dr. Bob Bollinger is the Raj and Kamla Gupta Professor of Infectious Disease. He is a Professor of Medicine, Public Health and Nursing. He's also the Director for the Center of Clinical Global Health Education. He's the Associate Director of Medicine at the Center of Global Health, and he's at the Johns Hopkins University School of Medicine.
Thank you very much, Ashish. It's a great pleasure to be able to participate in this webinar, and thank you again, and good evening to everyone in India. I was asked to make a few remarks about lessons learned locally and how they could be applied globally. So I will be talking a bit about what we've learned here in the United States that might be of help to others in India as you're thinking about this epidemic in your own community. But as I was thinking about this, I was reminiscing a bit because I had my education in public health and infectious disease actually began not at Hopkins, but in India in 1979. So I've had the great privilege of being able to work with colleagues in India for over 40 years in infectious disease and public health. And my lessons learned were local lessons learned in rural Bihar, in Maharashtra, and other places where I've worked for many years. And so I think we're going to learn, we learn a lot from each other, and I look forward to being able to share. So thank you again very much. I was asked, as I said earlier, to talk about some local lessons learned that perhaps might be helpful for others, and particularly in India, as you're thinking about where this epidemic is headed and what your needs and challenges are going to be. So I would focus, and obviously this is a big topic because there have been many lessons learned, but I'm going to focus on a few lessons focused on transmission. Secondly, public health, and then as a clinician, I'll talk a bit about what I think we've learned that might be helpful on the clinical side. So let's start first with transmission lessons. One of the things we've learned here in Maryland in the United States is that early in the epidemic, certainly, much of this new infections were occurring in what we call hyper-spreading events. And in our setting, they would be things like nursing homes, prisons, manufacturing, particularly food processing plants where people were in a contained space and working close together, church services, weddings, etc. And also healthcare settings, of course, early in the epidemic. But now what we've learned is as the healthcare system has begun to respond, the healthcare settings are getting safer now. They were not as safe early in the epidemic. So like a lot of places, some of the first people getting infected were unsuspecting healthcare workers who early in the epidemic, we didn't have testing available. So people were getting exposed both to asymptomatic and symptomatic patients before we knew that this was a COVID epidemic. The other lesson learned, and I think perhaps you're beginning to see this in India as well, is that the profile of infected persons has been changing over time. And I'm going to illustrate locally what that means in Baltimore, and I think it might be helpful in some of your other communities to think about this. So this slide just shows on the left the number of new cases reported per day in my state. And you can see here we are at the end of May, and there's been, there are peaks periodically during the week that are related to delays in reporting to the public health system. But you can see that it's been increasing and it's beginning to flatten out. But frankly, we really have not seen over the last few weeks a decline in new cases. So we're seeing about 1,000 new cases reported every day, and we have for weeks without much evidence that it's declining. However, if you look on the right side, this shows the hospitalization rates. So you can see that we had a big increase in hospitalization rates and now a decline in hospitalization rates. This is the ICU bed requirement, the lower purple bar. This is other acute hospitalizations. And so unlike a lot of my colleagues in India, we're only admitting to the hospital people that are acutely ill. I know in some settings, even mild symptomatic contacts of COVID patients are being hospitalized. But in the United States, we're only admitting people to the hospital who are sick, really sick. And you can see a decline. So why would we see a decline, a big increase in hospitalization and severe illness, and now a decline, and yet at the same time, we're seeing a not much of a change in the reporting of new cases? Well, one reason is because early in the epidemic, certainly here in Maryland and in Europe and other places, the majority of people that were becoming ill were elderly, and many of them were in what we call congregate facility settings, what we call nursing homes, where elderly people were cared for with a lot of chronic illnesses. And over here from our state yesterday, about half of the 2,000 deaths that we've had so far in our state have been in people who were elderly from these nursing home facilities, and that's what's reflected in that really stark increase in hospitalization and deaths early. But over the last few weeks, we're seeing a change in the epidemic, and this is shown here. If you just look here on the right first, you can see that, for example, this large blue bar here, the majority of new cases in the last few weeks have been from Hispanic members of our community. These are people from Latin America, from Mexico, Central America, who are generally younger, who are living in tight, controlled settings. They would be equivalent, perhaps, to some of the settings where your migrant workers live in closed communities with each other. And because that's where the epidemic has now moved from the older nursing home facilities to the community, to specific parts of the community in African American population shown here and in Hispanic population here, we're seeing a change in the epidemic. And we're also seeing that younger people becoming infected, and therefore we're not seeing as much need for hospitalization. But that could change as those same people expose older relatives or older people in the community. And so we could see another peak again of hospitalizations over the next month or so. So let me talk briefly about public health lessons. As I mentioned, elderly people with comorbidities were at greatest risk and continue to be at greatest risk for severe disease. And in general, our lesson has been that the highest risk people actually are more likely to follow guidelines. Our poor and marginalized communities are just not able to follow guidelines because of lack of resources, lack of opportunity. And so that's putting them at greater risk now. And thirdly, I think this is true all over the world. Young people in general are impatient and less likely to follow guidelines. I mean, I've raised 3 children, and I know what that means. They're not good listeners, if you will, at that age. So it's very difficult, and we've seen examples of that not only in our own community but all over the world, where young people were ignoring guidelines to practice physical distancing and masking. And then finally, and this is something Dr. Sharma mentioned, that I think, and I emphasize as well, is without clarity, consistency, and transparency and honesty in communications, we have a problem. And we certainly have a problem here in the United States where our leaders are not being clear and consistent, and therefore it's no surprise that the community is confused. A good example is illustrated here about masking. We have a big controversy now because our own president refused to wear a mask. People, I don't think, understand why they're supposed to wear a mask. I think we haven't done a good job in communicating clearly, not only from our leaders, but even from our public health officials about some of these public health lessons. And so finally, I'll talk about clinical lessons. I think, and there are many that we've learned. First, and I'll say a little bit more about this in a moment, is around the diagnostics and its role in our clinical management and diagnosis of patients. And there's a lot of discussion around this issue of false negative and false positive nucleic acid tests. And I'm just going to mention some more detail about that briefly in a moment. But I also think, and as I illustrated earlier, another lesson is that the clinical syndrome, how people present clinically, and their risk of progression, as we know, is age and sex dependent. And I think that's why we saw here locally a what's happened in Baltimore and in Maryland is that early on there was a lot of morbidity and mortality because the older people with underlying health conditions were getting infected. Now, I wonder, for example, whether you're going to see a reverse of this situation in India, in some communities, where the majority of people who are getting infected now are relatively young. You have a young population. But as those same young people who are relatively well with this disease carry that infection into their homes, into multi-generational families, and into their households, whether you're going to see an increase in serious illness over time as more elderly people or people with underlying conditions become exposed. One interesting thing we've seen here in Baltimore, for example, is that we're seeing a lot of younger people, particularly in the Hispanic and African American community, who are presenting with severe disease. And also in that process of presentation, we're finding very high A1Cs in people that had no idea they had diabetes. So it's uncovering an underlying epidemic of diabetes. And so, for example, in a place like India, where both diabetes and chronic obstructive pulmonary disease are quite prevalent in some populations, you may begin to see as the epidemic moves from relatively young, healthier people into a middle-aged population or people with underlying diabetes risk or COPD, you might in fact see an increase in sicker patients. A related issue is the biphasic illness that we're seeing. Certainly people are presenting, in general, as you've heard, and we're seeing this in Baltimore as well, that they often present with a standard upper respiratory or lower respiratory infection that's probably a viral pneumonia initially. They often get, many of them will feel better after a week or two. They're discharged from the hospital, and then they come back in around day 14 or to 21 with a much more severe immune-mediated inflammatory condition, and that's responsible for a lot of the patients on ventilators now for many, many weeks in our hospitals. And many of them are coming in with what we call asymptomatic hypoxia. They don't feel short of breath, so they don't realize that they're exposing their end organs to hypoxia. And so when they get into the hospital, they're presenting quite ill and quite late with renal failure, cardiac disease, and other complications of asymptomatic hypoxia. And so we're beginning to think about strategies about discharging people with a little more close follow-up, for instance, using home pulse oximeters or portable pulse oximeters in some patients at high risk to try to identify people that are hypoxic and perhaps prevent some of the end organ damage and need for ventilation that we see in the post-inflammatory process. We're having a lot of discussion about clinical management issues. One of the big debates is whether we should be intubating patients earlier or later. And that's still a debate that's going on. In some hospitals up in New York, patients were intubated late, and they had a very, very high mortality. At Hopkins, we've been intubating people a little bit earlier, and we've had a little bit lower mortality. Now, is that because we've intubated a different population of patients or not? We still need to sort that issue out. But a good lesson learned, and this is going to emphasize my final point, is that we learned very early from our colleagues in New York who were facing the epidemic before we were really facing it in Baltimore, that early proning of patients before they needed intubation was quite helpful. And we started implementing that very, very early in Baltimore in our patients. Found a simple intervention like proning patients who were having hypoxia could have a dramatic impact on many of those patients. And so I think these are also lessons learned, that there may be simple steps that sometimes can have a big impact on your management of these patients. Finally, I want to mention treatment. We can say more later if we want about hydroxychloroquine or chloroquine and some of these other suggested treatments. But I, from the very beginning, and I remember getting phone calls and emails from colleagues in India in February asking whether their father or mother should be taking hydroxychloroquine. And I had colleagues, clinicians, doctors who were prescribing themselves hydroxychloroquine, both in the United States and in India, without any evidence that it would work. So I think I would urge us, one of the lessons learned is to make evidence-based decisions. And if there's no evidence, do a randomized controlled trial. And we're certainly seeing, for example, with the new remdesivir, data that a randomized clinical trial is very helpful, and we're also seeing with hydroxychloroquine, a lack of a randomized clinical trial is very unhelpful, and people were exposed to toxic drugs unnecessarily with very little clinical benefit. So I guess the final point again is that it's a lesson learned for all of us is that our local experience can inform our colleagues and friends, and we can inform each other. And so it's important for us all to continue to share information and our lessons learned with our colleagues. This epidemic is not going to wait. We have to be able to share our experiences with each other and help us manage this local problem at a global level. So thank you very much. Let me end with this. I did want to mention about diagnosis with nucleic acid. I'm sorry, Ashish. I'm just going to show this last slide, and this is I borrowed this slide from a colleague of mine, Dr. Natasha Cheetah. So this shows a pooled analysis of the nucleic acid test, and I just want to show. Can you see that? I just want to show that. Look at this top figure that you'll see here. This is a pooled analysis, and what this shows is the percentage of nucleic acid tests that were negative in patients who have this disease. And you can see here on the far left that at the beginning of infection, virtually 100% of the tests are negative. But as over a few days and as symptoms progress, of course, the percentage of nucleic acid tests in these patients that are negative declines, as you would expect, as viral load increases. But it never goes to zero. The average is around 25% at the peak time of symptoms around day 5 or 6. And over the subsequent week of symptoms, you can see here, and then it increases again. So if you look out about 2 weeks, 50% of people who've had symptoms for 2 weeks have a negative nucleic acid test. And so the sensitivity of this test for clinical purposes depends a lot on when the patient is tested. So I would just point that out as an example of something we learned early on. So somebody who presents with a classic clinical presentation with a low white count, all the symptoms, having a negative test does not mean they don't have COVID infection. And so that was another example of a lesson we've learned that we hopefully will be informative to others. But thank you very much.